My name is Lara Strick, and I am an infectious disease physician, and I was asked to talk to you today a little bit about infectious diseases in the correctional environment. I have worked in corrections for almost 15 years and have currently no conflicts of interest. And I was going to start by just talking about infectious diseases in corrections in general, and why we are talking about this at all, and what makes infectious diseases in corrections unique. And it relates mainly to the higher prevalence and incidence of these diseases in the correctional setting, partially due to the crowding living conditions, both due to inadequate ventilation as well as to the close quarters in many of the facilities. There also can be some common environmental exposures, as well as an increased prevalence of immunosuppression, which can lead to outbreaks, especially in the setting of cohorting, where many facilities used to put all HIV patients, for example, together in one unit, which led to outbreaks of other infectious diseases like tuberculosis. Infectious diseases can also be related to altered behaviors, both before incarceration as well as during incarceration, and these would include things like illicit drug use, including the making of moonshine, often referred to as hooch or pruno, tattooing and piercings, sexual activity, and food hoarding, which we'll talk about in a little bit more detail later. And infectious diseases in this setting can occur both as outbreaks as well as subclinical transmission. And the reality is infection prevention in this setting and management of infectious diseases in corrections are really critical to our nation's health. As they often relate to from testing and screening to they're involved in immunization, surveillance, outbreak management, as well as treatment and release planning to continue treatment after release. And therefore, correctional health really equals public health. And for many diseases, without addressing corrections, you will never able to truly impact the prevalence of some of these infections. So we're going to start off talking about bloodborne and sexually transmitted infections. So bloodborne infections would include HIV/AIDS, hepatitis C, and hepatitis B. Other sexually transmitted infections such as gonorrhea, chlamydia, and syphilis are also often more prevalent in the correctional setting, but we are going to focus mainly on the bloodborne infections. And so the reality is, although drug use is not allowed inside of prisons, that the same intravenous drug use that occurs prior to incarceration frequently continues behind bars. But behind bars, there is not the same access to clean needle exchanges as well as clean equipment. Similarly, tattooing continues behind the walls as well, without the professional shops with proper decontamination and sterilization. And therefore, handmade tattoo guns like this one on the slide are often made without access to ways to clean the sharp as well as using shared ink. Leads to transmission of many bloodborne infections. Sexual activity also contributes to the spread of many of these bloodborne infections, and many of the people who are incarcerated have risk factors on the outside, including multiple partners, participation in prostitution, as well as trading sex for both money and drugs. But the reality is sex continues on the inside. However, starting in 2003, there was a federal movement to decrease the impact and prevalence of prison rape. And the PREA, or Prison Rape Elimination Act, was initially created and was further modified in 2012. The reality is that sexual activity continues in prison, but it is very difficult to tell when sexual activity is truly rape versus consensual activity. Many experts believe that there actually is no such thing as consensual sex in prison, since it is by nature a coercive environment, and it is felt that there is an inability to actually consent within this setting. On top of this, in most systems, except for a couple of state prison systems and a handful of jails, condoms are considered contraband, and therefore, even though sex is going on, people do not have adequate ways to protect themselves. As a result of all of this ongoing behavior, prisons often is seen as a breeding ground for infections. But the reality is the evidence suggests that the vast majority of people acquire their infection in the community before becoming incarcerated. That said, correctional settings can be critical sites for the emergence of infectious diseases, which has important public health implications, both for treatment as well as for prevention. Now, although maybe not the breeding grounds that were first thought, transmission of bloodborne infections does still occur. There was a study in Rhode Island Adult Correctional Institute from 1998 to 2000 of males incarcerated for more than a year. And what they found over that period of time, when everybody was tested upon entry and retested prior to release, that the baseline prevalence of HIV in their facility was about 1.8%, but there were absolutely no transmissions of HIV over that 1 year period of time. That accounted for 694 person years. The prevalence of hepatitis C and hepatitis B, however, were significantly higher in the 20 to 23% range. And there was indeed transmissions, although they were not particularly common for hep C. There was an incidence of 0.4 per 100 person years. And the odds ratio for hepatitis C was most highly associated with intravenous drug use. Hepatitis B's incidence was even higher at 2.7 per 100 person years, which is not surprising given the higher infectivity of this infection. However, the transmission of HIV does occur behind the walls, and this was demonstrated in a study that was done in Georgia, where there is mandatory HIV testing upon entry and voluntary testing at any point during incarceration. And during the period between July of 1988 and February 2005, 88 male inmates seroconverted for HIV during incarceration. However, incidence really was not able to be calculated because people were not systematically tested during incarceration, in that it was only people that self-identified and asked for repeat testing. Given this data, however, even with the 88 seroconversions, the majority of males with HIV came in already infected prior to incarceration, with 91% of male inmates coming in already infected. Given that these bloodborne infections are more common behind bars, prevention programs are very important for both addressing risk behaviors on the inside as well as upon release in the community. And prison and/or jail is a place to give those at highest risk knowledge to protect themselves from getting and transmitting bloodborne pathogens, and therefore it is important to educate both those people who don't have the infection yet, as well as those that already do. So specifically related to HIV, you can see in this graph that at the year end 2008 that the overall prevalence of HIV in the U.S. general population was 0.4%. The rates in prison were significantly higher, but they still are relatively low when compared to other diseases like hepatitis. And these infections, HIV, hepatitis C, and hepatitis B, tend to always be slightly more prevalent behind the walls among women compared to men. And that probably is related to the fact that the number of women who are incarcerated is significantly smaller and a much more marginalized population compared to the very large population of men behind bars. So therefore, among women, the prevalence of HIV was around 1.9%, while it was about 1.5% among men, which is still more than 3 times the general population, 3 to 4 times. However, this higher prevalence in prison is not evenly distributed across the country. You can see in this map that the majority of people with HIV who are incarcerated concentrate in the Northeast and in the Deep South. And that is probably related to the fact that the epidemics of HIV among these areas differ, in that in the Northeast there is a predominance of HIV among the IV drug using population, and in the South among the heterosexual poor, which has a much higher overlap with incarceration compared to the epidemics where the majority of those infected are men who have sex with other men. And in January 2009, the CDC finally made guidance specific for the correctional setting related to testing for HIV and highly recommended routine opt-out HIV testing, given that there is a higher prevalence and therefore more cases can be detected. However, there are some barriers to HIV testing in the correctional setting, in that there is a huge concern among the patients related to confidentiality of the results and their care. And it is often very difficult to maintain confidentiality in such a closed setting. There also could be system limitations or disincentives, in that frequently people who are incarcerated have priorities different than us as physicians, and not uncommonly would prioritize visitors, their family, job opportunities, and programs more than access to good HIV care. And therefore, by knowing their HIV status, if it prohibits them from going to other facilities that may favor their other priorities, they may not want to know their status while incarcerated. This is also a population that has a lot of denial and or mistrust of authority, and that they have often had very negative experiences with authority figures, starting with their parents at a very young age. This is a generalization, but the reality is that we as physicians are authority figures, and that trust among this population is really earned and is not a default. Many people who are incarcerated have never had experience with medical or healthcare services, and therefore adds to the mistrust of the healthcare community. There frequently is a cost associated to seeing medical providers in certain facilities, but there is also a cost to the facilities to pay for the medications, which may also be a disincentive for them to test and identify more people who are HIV infected. It also leads to a requirement or responsibility to link people to care once they release, and highlights the importance for the need for collaboration with public health and other community organizations. This chart is an example of what different testing strategies and acceptance by a correctional population might look like. This was a report from Washington State, and in red was the number of people who got HIV tested when it was by request only. And you can see that during those years, a small number of people actually requested testing. Then they switched over to opt-in testing. And the average number of people who got tested went up considerably to about 72%. And this is where, when people entered the prison system upon intake, they would be asked if they wanted an HIV test or not. Lastly, in yellow, was when they switched over to opt-out HIV testing, and you can see that the acceptance rate of testing went up even higher to about 90%. Opt-out testing is where patients are told that testing will be done on everybody unless you refuse. So it destigmatized getting testing, as the default is to get tested, and the act would be to opt out or refuse testing. And this is a chart of the correctional HIV care cascade. And what this shows us is, in the white bars, is each point in the cascade that people, while they're incarcerated. So what you can see is during incarceration, there is a greater likelihood that people are in care, that they are retained in care, that they are on antiretroviral therapy, and that they have an undetectable viral load. But then if you looked at the cross-hatched bars, which is after release, that the likelihood that all of these things are true are significantly lower, and often even lower than prior to incarceration, because they often lose their connections to their community providers. And so it highlights the necessity or responsibility that we have to ensure that after engaging people in care during incarceration, that we really link them to care upon release. While incarcerated, it may be their first entry into regular care, and these programs can include screening, prevention, as well as health education, and not just solely upon care itself. And it's an opportunity to build trust and a relationship with the provider to help improve the likelihood of engagement after release. Then we're going to switch gears over to hepatitis C. So hepatitis C prevalence in the United States is only about 1 to 2%. But the estimated rate of hepatitis C in U.S. prisons is as high as 41%, with an average of about 17.4%. And about 1/3 of U.S. hep C cases pass through the correctional system. The problem is that data is extremely limited, as most systems do not routinely test for hepatitis C. And so we are not truly able to measure the number of people incarcerated with this disease. Now, the issue with hepatitis C that often leads to a lot of the controversy is related to the natural history, in that of people who have chronic infection, not everyone goes on to develop cirrhosis and end-stage liver disease. And even if they do, it often takes a long period of time to get to the stage where people become symptomatic. And so it is not infrequent that correctional systems defer the treatment of hepatitis C to the community, since it often is not likely that the benefits of treatment will be felt by the system itself, since people will release before the time they have extensive disease. However, hepatitis C treatment is finite, and it's getting even shorter, and treatment is even becoming more feasible in jails, given that there now are 8 and 12-week regimens. These shorter regimens are exceedingly simple, with fewer pills, less side effects, and are just easier to take. And unlike HIV, treatment for hepatitis C is a cure, and it is increasingly effective, with rates of clearance 90 to greater than 95%. However, the problem is treatment is extraordinarily costly, and it probably will take years to decades before treatment is available to the numbers of people where it could simultaneously be a method of prevention. I think part of the controversy is related to the fact that people with hepatitis C in corrections often will release and go back to similar behaviors and begin injecting again. And being cured of hepatitis C does not protect you from getting reinfected. We know reinfection happens, but there is little data on the rates of reinfection, especially in the United States. There are some studies that have been done in Australia, including within their prison system. It does appear with the data that we have to show that having had the disease before does give you some immunity in that it's harder to get a second time, but it does happen. And it really, to me, stresses the importance of marrying treatment programs with risk reduction counseling and programs, because it's not the drug itself, i.e. heroin or methamphetamines, that cause hepatitis C, but the behaviors and learning how to safely inject, have sex, or tattoo can prevent reinfection, even if people choose to continue to engage in these behaviors. Now, there is some data to show that the earlier people get treated, that there is an increasing benefit. But the reality is that corrections continues to have a need to prioritize. Even if these drugs get significantly cheaper, it would be impossible for any system to treat the numbers of people with Hep C simultaneously all at once. And so therefore, correctional systems have to balance population health versus individual health. And this is a little bit different than in the community, because in the community, physicians really don't have control over who their next patient will be and who will make an appointment next. But in correctional facilities, like in some managed care plans, there's an ability to look at the entire database of a population and see people in the order that they need to be seen from a clinical severity standpoint. It doesn't mean that we should limit treatment from certain patients, but it does impact the order in which patients should be treated. And you could argue that it would be unethical to treat patients in an order other than treating those of highest necessity first. However, there is the question of how to prioritize, and I think that there is those who would solely prioritize based on clinical severity, in that those who are at higher risk of complications of the disease and have more advanced scarring of their liver, versus treating those that may have the greatest impact on transmission of these diseases. And so some would argue it actually makes more sense to treat those that may actually be engaging in high-risk behaviors, in that those are the patients that are more likely to transmit this virus. Turning to hepatitis B, hepatitis B is very prevalent among those who are incarcerated and is fivefold the general population. And among patients with acute hepatitis B that are reported to the CDC, about 5.6% have a history of incarceration during the disease incubation period, intimating that they likely got infected while incarcerated. There have been outbreaks of Hep B that have been well documented in correctional facilities. And the prevalence of Hep B, as we've already talked about with all of these diseases, is higher in women than it is in men. But by the time people get infected with Hep B, you've sort of missed the 8 ball. Because, and the fact is that there are these unfortunate outbreaks, which sometimes are symptomatic with jaundice. And this was a case, a cohort in Georgia that had symptoms of hepatitis B. But once they recognized those people with symptoms, they found that there were many other people throughout the facility that had subclinical acute hepatitis as well, both in the same dorm as those with acute hepatitis, as well as in other parts of the prison. And 20% of the cases reported sex with another inmate. However, we should not be waiting until people become symptomatic or have evidence of Hep B, because Hep B is totally preventable in that there is a vaccine. And the recommendations are that anyone who is incarcerated should be vaccinated for hepatitis B since it is considered a risk factor due to the higher prevalence. And some states do have collaborations with their public health counterparts to do mass vaccinations for hepatitis B in the correctional setting. So to totally switch gears now from bloodborne infections to infections that are spread by close contact, airborne, and droplets. So examples of close contact infections would include methicillin-resistant Staphylococcus aureus, or MRSA, zoster or shingles, ectoparasites like scabies and lice, all of which are more common in the correctional setting. Similarly, airborne and droplet infections like tuberculosis, influenza, measles, and mumps, as well as varicella, are also more common, particularly in the federal system where you see more foreign-born inmates. You have more likelihood of seeing outbreaks of measles and chickenpox due to the lower rates of childhood vaccinations and exposures to these diseases. These diseases are directly related to overcrowding of prisons, and this is a famous picture from the California prison system that shows inmates being stacked 3 bunk bed high into living areas and outside of the usual dorms due to overcrowding. You can also imagine these are what a cell block would look like, and inside of a cell where 4 inmates would have to live together for long periods of time, how diseases that are spread either by direct contacts, air, or droplets could easily be transmitted within this environment. Here is an example of a dining room or chow hall. But it's important to realize that correctional systems are not closed systems, and that there is a constant flow of incoming and outgoing inmates. People move due to request because their custody status changes. People get into trouble and go up in security. Over time, with good behavior, they may go down security levels. They frequently have to go out to jail or to court because of outstanding warrants, and they cycle from the community back into jails due to parole or community custody violations. Transfers occur frequently between systems as well as between facilities within a system. There are visitors who come in and out and bring additional exposures from the community. But another source of exposures from the community includes the staff. So it is not always inmates exposing others. It frequently is staff and visitors bringing diseases in as well. This is an example of a transport bus. You can see the line of buses on the top picture, and in the bottom picture they may be seated in these seats where they would be chained or cuffed in place for hours at a time to get to the next facility. In the federal system, their facilities are often states apart, and this is an example of a facility in Oklahoma City that has its own runway with planes coming and going, bringing inmates in and out. So all of these features lead to a rapid transmission of some of these diseases that can cause huge outbreak investigations. And there are particularly high rates of tuberculosis in corrections. And in mid-year 2003, although 0.7% of the U.S. population was incarcerated, it accounted for 3.2% of the tuberculosis cases in the United States that occurred in a correctional facility. So tuberculosis was overrepresented in corrections compared to the population it contained. And these TB outbreaks occur particularly in jails and federal prisons. The prevalence of latent tuberculosis infection can be as high as 25%. And it's partially because the incarcerated population is at high risk for tuberculosis, with drug use, low socioeconomic status, homelessness, and HIV all being risk factors for getting this disease. We've talked about the fact that the physical structure of the facilities themselves can foster rapid transmission due to the close living quarters, inadequate ventilation, and overcrowding, as well as the number of foreign-born inmates and staff that work in these facilities. There have been several TB outbreaks in correctional systems. From 1990 to 1991, New York State Correctional System had an outbreak of multi-drug resistant tuberculosis. They had 171 inmates with TB, 37 had multi-drug resistant TB, and it wound up involving 23 of their 68 prisons. And transmission of TB in prisons is often linked to their population density. So the more crowded, the more likely there will be transmission. Lower rates of treatment of latent tuberculosis infection, and duration of incarceration. And this is an example in how complicated an investigation of a TB outbreak in a correctional facility can be. So this was a federal pretrial facility in 2010. The patient came from the black circle in the middle, and by the time the patient was identified and there was a search for contacts, 388 contacts were identified, of which only 84 remained at the facility where the patient was located. 102 inmates had already been deported and were in multiple countries that needed to be contacted. 101 had already transferred to other federal facilities in green. Several were in transit via the U.S. Marshal Service in yellow to other facilities around, contracted facilities around the country. And 38 had already released to the community in California in blue. So these can become extraordinarily complicated investigations and are best caught as soon as possible in the course of disease. Therefore, the CDC recommends screening for latent TB at intake into any correctional facility. There should be a symptom screen immediately upon arrival, and if no symptoms, a skin test or tuberculin skin test, IGRA, which is a blood test, or a screening chest x-ray should be done within 7 days. If someone's immunosuppressed, the recommendation is to get a chest x-ray regardless of those results because they are not considered reliable. Symptom screening alone is not considered satisfactory except in facilities with minimal risk, and the reality is there are very few facilities that would meet that definition. For some facilities, there's such rapid turnover that tuberculin skin tests or blood tests are not practical, and so larger jails frequently will opt to do a mini chest x-ray for screening. The recommendation is not to house newly arrived inmates with others until they're screened for TB before they join the general population. And currently, annual screening is recommended, although it's unclear if this is necessary and how much it picks up tuberculosis cases. Influenza is also much more frequent in this setting since it is a congregate setting, and can often be the sites for emergence of epidemics because of these close quarters. So, for example, Fort Riley Military Institution and San Quentin State Prison were actually the first locations where 1918 epidemic flu emerged in the United States. And flu really is the most likely pathogen to cause serious health and safety concerns due to rapid spread in facilities like this. It is just much more contagious and spreads much more quickly than some of these other diseases. And in 2008, for example, at the Federal Medical Center and the Bureau of Prison System, 117 inmates and 110 staff were affected in a single season in this facility. And so therefore, surveillance of infectious diseases in correctional settings should really be national public health priority, both to minimize impact as well as recognize new emerging infections. Lastly, we're going to turn to environmental and behavioral infections. So environmental infections would include things like Coccidioides immitis, which we're going to talk about in a little bit more detail. Legionella, which is often spread via air ducts, air conditioning vents, and water supplies, as well as foodborne infections, which can become quickly rampant if the food in a facility is contaminated. Infections can also be related to the behaviors of the inmates themselves. So there frequently can be tattoo-related skin infections that are not seen as commonly in the community due to contaminated or unsterilized equipment and ink. There have been outbreaks of botulism due to making your own hooch or pruno in the units using bread, fruit that is left to ferment over time. There has also been salmonella outbreaks because inmates bring food from chow hall back to their cells and eat it later where they don't have proper refrigeration, leading to the growth of the bacteria. So first let's focus on cocci. In general, cocci is a self-limited illness and is asymptomatic and resolves in 2 to 3 weeks without any therapy. And once you've had it, you develop lifelong immunity. It's a fungus, and the issue is that 5% of people do develop symptomatic pulmonary disease that can lead to nodules, cavities, and chronic lung disease. And even more rarely, less than 1% develop disseminated cocci, where they can get involvement of bone or they can develop meningitis. In certain ethnic groups and the immunocompromised are at greater risk of getting these severe manifestations. The issue is cocci is endemic in the areas of the United States highlighted in red. The problem is that when you incarcerate somebody in the areas of red, they may not be from those areas. And so therefore you're taking people who have never been exposed to cocci in the past, and you now put them in a correctional facility where cocci is endemic. And in the California prison system, they did an evaluation in 2011 and found that there were 2 prisons that consistently reported greater than 80% of California's cases because they were right in the middle of the San Joaquin Valley where the majority of cocci resides. And they found that the risk factors for severe and disseminated cocci included being African American, more than 40 years old. Black race was also a risk factor for disseminated disease, probably because many of them had not been to this part of the country prior to incarceration. Diabetes was a risk factor for severe pulmonary cocci. And the California court system actually made a decision mandating the exclusion of blacks and people with diabetes from 2 California prisons with the highest rates of cocci. It's important to keep on your radar, though, because even after transferring out of a cocci endemic area to a prison elsewhere in the country, they can still develop the disease later on after the transfer. The good news is that this disease is not transmissible person to person, and you actually have to be in the area and have an exposure in order to get it. Moving on to some of the infections related to altered behaviors in the prison setting. So there were several reports in the community about non-tuberculous mycobacteria that was associated with tattooing, and you can see here the red dots that follow the pattern of the ink. But in prison, due to the inability to sterilize equipment, we also see MRSA related to tattooing. And in this particular outbreak in the Bureau of Prisons, there actually were 15 cases, one of which needed to be hospitalized, all of which grew MRSA, that were traced back to a single artist using contaminated equipment. I've also seen warts associated with the human papillomavirus associated with tattooing. You can see the flat-topped brownish lesions that again follow the pattern of the ink, that likely the needle passed through a wart and got contaminated and spread it throughout this tattoo. Although correctional facilities are a place of increased prevalence of infections, there are both advantages and disadvantages of managing these infections in this setting. And so the reality is the primary goal of correctional facilities is to keep the community safe. They're not designed to be healthcare oriented, and health services is only one piece of a very complicated system. There's a large number of the inmate population that is distrustful of the system, as we mentioned. The prevalence of things like personality disorders, mental illness, and historical trauma are much greater among people who are incarcerated, that are barriers to engagement in care. Different services may be available at different sites, and we talked, for example, about facilities of expertise. There might be multiple points of care in the system, and people are transferred from facility to facility and system to system, in which medical records, information can get lost in the juggling of their care. There frequently are unscheduled transfers or releases, not allowing for proper arrangements to be put in place, and all of the systems struggle with limited resources. However, you usually can find your patient by the end of the day. There is much more control over housing than there is in the community, and you can put patients on medical hold, barring transfer to another facility. And you can specify their cell assignments. Many settings have 24/7 health care, and as well as pill line, which is a way that medication is dispensed at times in this setting. And all of these allow for greater oversight compared to the community. Even when they're on community supervision or parole, the parole officer can help keep tabs, if necessary, on a patient. However, I want to talk briefly about dispensation of medications in prisons and jails, as I think this often gets misinterpreted. There are two ways that medications are given out in this setting. One is referred to as keep on person, or KOP. Sometimes other facilities call it self-administered therapy, or SAT, as opposed to pill line, or DOT, or directly observed therapy. The reality is most medications in larger facilities are actually keep on person. It's more convenient. It gives the patient more empowerment and responsibility. They're not given labels as a narc or being mentally ill, as those are the majority of medications that are restricted to pill line. It prepares people for the community of setting up a habit that they will need when they release. But they may only want keep-on-person medications if they trust their cellmate or cellie. This is in contrast to directly observed therapy, which a lot of people assume results in greater adherence. But pill line really is a way of monitoring therapy, not necessarily assuring adherence. It avoids confiscation by custody, and for many patients, it helps remind them to take their meds, especially if they're already on mental health meds anyway and going to pill line. But the few studies that actually have been done looking at keep on person or self-administered therapy compared to directly observed therapy did not show that it improved adherence. And if anything, people did better taking medications on their own, and the majority of people reported that they preferred taking the medication on their own. And so it's not clear to me that in a correctional setting that directly observed therapy is indicated or necessary in order to ensure adherence as opposed to just education and empowerment of the patient themselves. And the way they did this study is you can see for the adherence rates for directly observed therapy was about 82 to 89% using MEMS caps, which are electronic caps that can register every time a bottle is opened, as well as pill counts, compared to self-administered therapy or keep on person that averaged about 90 to 92% adherence rates. So why is adherence better while incarcerated? It's obviously not because every dose is observed, but it probably relates to the fact that people who are incarcerated have a very structured lifestyle. They have guaranteed housing, 3 meals a day, and at least less drug use. They potentially have greater access to treatment of mental health disorders, and therefore it allows them to have more focus on health and well-being in that they don't have to worry about these other life stressors, and often have easier access to care than they would in the community. And I will end there, and I hope you enjoyed the overview of infections in the correctional setting. Thank you.